So welcome everyone. This is a podcast for the Journal of American College of Cardiology, Electrophysiology Journal. We're going to be doing a simultaneous publication of this important paper from our institution, Brigham and Women's Hospital. I'm Usha Tedrow, and I'm one of the associate editors here at JACC, and I'm joined by Dr. William Sauer, who's the chief of cardiac electrophysiology here at the Brigham, and one of our senior fellows, Dr. Robert Kerley. And I was wondering if, Robert, if you could start to go over the paper and talk about some of the important findings.
Sure. Thanks, Dr. Tedrow. This paper was a paper looking at our experience with 15 patients in total. It was looking at high-power, short-duration radiofrequency applications to target Purkinje tissue for the treatment of ventricular fibrillation. The method of targeting Purkinje tissue to treat ventricular fibrillation has previously been described. We were specifically looking at a biophysics angle, Purkinje tissue being more subendocardial, more superficial, and looking at high power short duration, which, as we know, has previously been used to target the posterior wall, as it creates more shallow lesions, and the substrate that you're targeting is more shallow. So theoretically, specifically targeting the tissue while maintaining as much healthy tissue as possible. So this was a prospective analysis of 15 patients undergoing vesicular substrate modification targeting Purkinje fibers. We used high power short duration. This was either at 90 watts for 4 seconds or in some cases 50 watts for 10 seconds. And the endpoint was elimination of Purkinje-like potentials at the end of the procedure. So this was a study from ourselves here at the Brigham, and it was also our colleagues over at the Cardiac Rhythm Service in the University of Washington, as well as in Elyria in Ohio. So in terms of results, 15 patients in total. We had their mean age was 48, plus minus 16 years, 40% female in the study. It was primarily transeptal access. In 10 patients, 5 patients underwent a retrograde approach. Mapping was done pre and post to look for healthy myocardial voltage, and the mean follow-up was 7.5 months with a median actually of 7 months. We saw a significant reduction in the number of VT-VF episodes. For those who are watching online, this is here in figure 2, but for those who might be listening, the treated VT-VF episodes reduced from 4.5 plus or minus 2.9 pre-ablation to 0.1 plus or minus 0.3 post-ablation, which was statistically significant, and that was at a mean follow-up of 7.5 months. We had 2 recurrences that were noted, one in a non-ischemic cardiomyopathy patient at 87 days, and another non-ischemic patient at 112 days post the index procedure. So overall, the results suggest this is quite successful. We saw the technique treat the arrhythmia, and on our post maps in all cases showing preserved healthy tissue. For those who are watching online, you can see this in figure 1, where it's clearly healthy pre and post the ablation with targeted high power short duration lesions at 90 watts for 4 seconds. So in conclusion, vesicular substrate modification by catheter ablation targeting Purkinje-like potentials using high power short duration is feasible and appears to be safe with high rates of acute AF non-inducibility and reduction in recurrence.
Wonderful. That was really a great summary, Rob. And I was wondering, Will, would you be able to talk a little bit about the idea behind this? I thought it was really an ingenious idea to target these like superficial Purkinje fibers that really previously, we had a lot of trouble with irrigated RF in those areas with a lot of automaticity. Catheter stability can be a problem. Could you talk a little bit about that and the motivation for the study?
Yeah, well, I think it's fitting that I don't know if you caught this, but Rob slipped a little bit. He said, no recurrent AF, and I
Oh,
think
sorry.
that's because no, it's fine. But I think that's because this technique is really important when we were doing radiofrequency ablation on the posterior wall. We wanted to create a nice shallow lesion. We didn't want to injure the esophagus, and I think that the whole rationale of leveraging leveraging the resistive heating of the first initial seconds of high power was really applied to that thin structure on the left atrial posterior wall. However, this is a great example of how we can use this in the ventricle, because we really are just going after a shallow structure. Those are the Purkinje fibers that are just subendothelial. And so we're kind of doing that same exact, using that same strategy. And I'm very excited about the results for this. I really hope that the word gets out that VF is something that we can treat with denetworking. That wasn't our idea. I think that's been around for a little while, and but I don't think everybody is necessarily doing this. And I think using this strategy it makes the procedure faster, safer, as you had indicated that a lot of times when I was ablating near these structures, you would have inadvertent VF that was induced with this. And one of the reviewers of this paper actually made a comment on that, and maybe I can have Rob talk to a little bit about that, about our experience with the VF that we sometimes see with ablation. But yeah, I think it's an ingenious idea too, Usha.
Yeah, Rob, would you like to speak a little bit to that? And then maybe we might also talk about the potential consequences of inducing left bundle branch block in some of these patients. Do we have any thoughts about that, whether there are any negative effects of this treatment?
Yeah, so in terms of inducibility, it was extremely common across the group to get inducibility, particularly with catheter manipulation. Whenever you were near the posterior fascicle, you would either get non-sustained polymorphic VT or multiple PVCs. We actually had one case, I think it was with you, Dr. Sauer, where we were linking the EGM from what we were getting from bumping on the posterior fascicle to the patient's recorded EGMs from inducible VF, and they matched very, very closely. And that was extremely common across the three sites where we performed this study, primarily with catheter manipulation, more so than pacing. And typically, at least in the cases that we recorded here and that I were scrubbed in, once you start performing ablation over that site, particularly over the more disease segment, which is mostly the posterior fascicle, you saw a dramatic reduction in both the excitability, PVCs, as well as induction of non-sustained either VF or polymorphic VT post ablation. So I do think there's a significant improvement once you treat that site. In terms of the energy that was used, it was in 5 patients. It was 90 watts for 4 seconds, and then in 10 patients it was 50 watts for 10 seconds. So a little bit of variability, which I think over once we continue this study, we'll try to see if there's any difference between those two. But for the time being, it seems that they're both quite effective methods.
Great, great. And Will, do you want to talk a little bit about the potential negative effects of inducing left bundle branch block in some of these patients, and whether that's a problem, or did you restrict ablation to areas with damaged Purkinje fibers only? Can you speak to that a little bit?
Yeah. For the people viewing this, you'll notice that the figure, there's like these little orange dots over at the top near the aortic valve, and that was representing sort of the more proximal fascicular system. We tried to avoid that, actually. We didn't want to, if we induced left bundle branch block, I would consider that a complication. We're trying to get at the little tiny arborization of little, fascicular fibers that are distal. And we have seen a non-significant increase in the QRS duration afterwards, and that's in the paper where it was P of 0.09, I believe, where we basically saw a slight increase in the QRS duration. In terms of looking at, one of the reasons why these patients are having VF is because they likely have diseased fascicular tissue. And sometimes we'll see it like in this figure here on the poster, buried in the QRS complex, or buried in the ventricular electrogram. Sometimes we see it all the way delayed, like almost like a local block. And so we're targeting these fascicular potentials, but they could be before the inscription of the QRS complex, within the QRS complex, or afterwards. And so, the end point of this is really to have none of those tiny little electrograms. We don't even want to see the blocked ones. We want to basically get all of the tiny little those fascicular electrograms, because we believe that they are important in VF initiation and maintenance.
Fantastic. I think this paper is so important. It really builds on the seminal work. I think the first paper I saw showing this type of targeting was from Bodie from a Texas group, and then also the Bordeaux group has used a very similar approach. So I think this really helps the technique along, and the paper is really important, and we look forward to the simultaneous publication. Thank you to everyone for joining.
Thanks for having us.